So we will be talking today about the management of agitation in the elderly. To be able to do that, we need to first define agitation. So what does it really mean? How do we define agitation? Agitation is a very subjective and vague word that usually in the elderly and with dementia means emotional distress, excessive psychomotor activity, pacing around, rocking movements, wandering, and then sometimes escalates to aggressive behaviors. It can mean irritability, disinhibition, plus or minus vocal disruption. Different types, examples could be purposeless hyperactivity, intrusive pacing, wandering away, as we said, exhibiting socially and functionally inappropriate or aggressive behaviors, being resistant to care if there's incontinence or accidents happening, as well as sleep-wake cycle disturbances. Agitations can come in acutely and suddenly, or have a more insidious or subacute progressions. So sudden onset of behavioral changes is usually indicative of a medical etiology, whereas slower, more insidious changes may represent a distress response to a change in the environment and the caregiver routine, which can happen with progression of dementia. So we will be talking about both situations and what we can do in each of those. Those agitations can occur with or without overt psychiatric symptoms. So that means we may or may not need psychiatric medications, and can occur with or without confusion and fluctuation of consciousness, which means we may or may not need to have some medical investigations. So in dementia research, there's a tool called the NPI scale to measure agitation. And if you get a score of more than 4, you're considered agitated. And if you look at the questionnaire, it's 8 questions listed below. It still remains difficult to quantify. And people can be stubborn or uncooperative at baseline with a personality. And so things are dependent on life events and circumstances, as well as modifiable factors that we can talk about next. So why is agitation so important? Because agitation leads often to aggression. It is associated with patient caregiver distress. It leads to harm to self. The patients can have falls, can wander, have accidents. It can harm others, caregivers, other residents in the facility. It leads to physical altercations if the escalation attempts fail. It does increase the risk of institutionalization if we're starting early, and it accelerates the progression to severe dementia and early death. So we're going to talk about first the environmental related causes of potential agitation. Sometimes in a room, excessive stimulation, noise, number of people, excessive clutter can lead to people being uncomfortable, folks with dementia. Inadequate stimulation could also do the same thing. And so having little or few objects to view or touch can also add to the agitation. Poor lighting can lead to visual disturbances and distress. Inappropriate room temperatures, if it's too cold, too hot, and our patients cannot express that or cannot realize that, they will become uncomfortable and then become agitated. Being disoriented, not knowing where they are, changing location can also contribute to agitation. Difficulty finding their own room. Even if it's the same room they go to every day, if the dementia is advanced, if you can't help them locate it, they will become agitated. Difficulty finding their bathroom or their meals, dining rooms can lead to distress and hence the agitation. So small environmental changes can go a long way. Having a quiet area, loud noises are very upsetting to people in general. Add to it someone who's having difficulties communicating or understanding. So having always quiet areas can go a long way. Ensuring that people have their own assistive devices. If they have their glasses, they can see better. If they have their hearing aids, they can hear better. And there's much better chances of having a good communication and less likelihood to be agitated. If the resident is yelling when the TV is turned on, that could be a sign that the TV is too low or too loud. Do we need a different channel? Do we need to make some changes to meet that need? Removing clutter and unnecessary objects can be trip hazards, can be overstimulating and unnecessary as well. Using labeling and other visual cues. A very useful one is arrows pointing to the bathroom, arrows pointing to the living room, and then names in big letters at the entry of their own rooms. Having daily structured routines that are predictable and easy to join in and join out seamlessly is also a way to keep minimal chances of disruptions. Activities that tap into preserved capabilities and previous interests. So even if our folks have lost some of their capacities, they still have whatever residual interest or ability to express they have, we should tap into. Using repetitive motion activities, washing windows, folding towels, putting coins in a container are all very soothing and relaxing activities that can minimize escalating agitation. And setting up the activity and help initiate it if needed. Sometimes our folks have difficulty starting the project. And so if you start with them and then they can continue, that is that is higher chance of success. There are new interactive tables and some therapies that involve light stimulation, combining colors, lights, sounds, to interact with nonverbal folks and folks who are unable to express themselves but can still enjoy their senses. And so this is one of many examples of available interactive tools that we can use using technology that can help people also enjoy themselves and have some sensory stimulation. We're going to talk about some communication tips while talking to someone with dementia. You always want to keep your feedback short and simple, straight to the point, with one-step directives. So state what you want to say to the person, show him or her at the same time. So if you want to say, comb your hair, and while making the gesture that allows the person to understand more and faster what's going on. Allowing extra time for the person to process and respond. Responses from person with dementia can be delayed by up to 30 seconds. So some patients, and allowing for that time, not rushing, can also be very helpful. Don't argue or confront. Sometimes we just don't know what was misunderstood. And so being confrontational never helps. Try to identify and acknowledge the feeling the resident is experiencing will be helpful. Are they confused? Are they scared? Are they tired? Are they in pain? And we will talk about those a little bit later. Don't use all your energy trying to change what is not within your control, and back off and come back later if it's looking like it's escalating and you're not able to do that verbally. Correcting or shaming or saying, no, you can do it, pressing people to give an answer that is not sure or certain that they can lead to frustration and increased agitation. Offering choices is often a good idea. So instead of saying, what do you want to eat, you can continue with offering the choices. So this way they don't have to look for the word. And remember and remind regarding personal preferences. You like the green one, you like to drink your water cold, and that will be very helpful as well. And when facing resistance, you have to be the person who's flexible and try a different approach. Folks with dementia often have decreased visual fields, and so they can be easily startled. That's why it's always recommended to approach them from the front, so that not to startle them. Make good eye contact if possible, stand in front of the person, pay attention to the personal space without being too invasive as well, and ask permission before any action, even though you think this is going to be very helpful. Asking permission will allow the patients to have their agency. Always lead with the person's name and introduce yourself, even if it's 3 times a day. That's always helpful. And then redirect it in a positive way, distract and divert. Um, um, a common one is, again, with the expectation and the confrontation. Sometimes it can be frustrating, even if you know the person knows your name but can't really say it at all times. Avoid causing frustration and agitation by asking the patient to identify you, um, and say, "Hey, do you remember me?" And if they say, "Oh yeah, how are you, doctor?" Or if they don't say it, and you know they can say it at times, we don't have to say it to hear it every time. And so forcing them to recollect will not help them recollect, and will just increase the shame and potentially the agitation. Nonverbal communication tips. Again, we talked about visual or tactile cues. Florence, please brush your hair, and then you demonstrate the movement of hair brushing. Watch your nonverbal messages. Tone of the voice, volume, and rate are all very important. So having a calm tone, a normal volume, and steady, not rushed rate is very helpful. In terms of body language, avoid crossing your arms. That can always be interpreted as being impatient or wanting to get things done quickly. Facial expressions, they have to be larger and more expressive than you would in a normal conversation. Smile reassuringly and try to be as expressive and as reactive as possible. I can't emphasize enough the importance of touch, and gentle touch and holding hands and gentle strokes are very important. We forget how important it is, um, and how lacking folks in a nursing home or in a facility are, how important a hug is, and how reassuring it can be. And so a gentle touch can be very calming and very rewarding for patients. Before touching them, though, you have to ask permission and you have to describe what you're going to say. I'm going to hold you now. I'm going to hold your hand. Is that okay? And then you proceed. And most of the time, it's very helpful gesture and very well received. In case of severe dementias, in most places we have animal-assisted therapies, doll therapies. It is instinctive to take care of younger or smaller creatures. And so even with folks who are completely nonverbal, completely apraxic, cannot are independent with all their needs, if you give them a doll that looks like a baby, they're gonna take it and they're gonna try and soothe the baby, and that by itself will soothe them. And so these are very common, very simple interventions that are helpful in our folks who are fairly advanced. There are now newer ones, and then AI-empowered dolls and pets that I don't know where that will lead, but they can be a bit interactive as well. And so you're not just soothing, you get a response and you get a purr maybe. And so that can also be very therapeutic. So in that space, that can also be encouraging and things to look forward to. So these were all the environmental changes and behavioral approaches that we can do to try and mitigate mild agitation or environmental factors that could make people uncomfortable. Sometimes, however, when we have dementia, we have difficulties realizing what our need is and expressing it when we do. And so I like to think of it as a failure to communicate. And agitation would be a response to an unmet need. And that unmet need could be very basic hunger, could be constipation, could be being cold. And if you meet that need, you don't have to use medications, you don't have to intervene and be aggressive, and we don't have to escalate things. And so being very mindful to bowel movements, to pain, and to the temperature of the room is always very, very important. And a second very, very important need is pain. And sometimes folks with dementia also have arthritis, also have chronic pain, back pain, knee pain, and they can't really say it. And so all sorts of causes of pain that can cannot necessarily be acute, can be chronic, and we don't realize that it's making folks uncomfortable. So multiple randomized control studies suggested and supported the use of analgesics empirically to reduce agitation. So there have been trials with Tylenol, with opiates, even with opiates and with gabapentin, and they noticed reduced symptoms of agitation, behavioral disturbances over 8-week trials in nursing home residents who were nonverbal. Just empirically providing them with pain relief made them calmer. In a Norwegian nursing home, there was another study where patients with moderate to severe dementia, verbal aggression, pacing, and restlessness responded well to personalized pain therapy using a combination of pregabalin, Tylenol, buprenorphine patches, and extended release morphine. So always good to keep in mind, is my family member, is my patient, is my loved one in pain? And could a simple Tylenol help this situation where I don't know why they're pacing, I don't know why they're agitated. So most of what was mentioned before was psychological, environmental things we can address. And usually another side of agitation could be medical. And sudden onset behavioral changes that is very abrupt and very stark difference is usually indicative of a medical etiology, and maybe a sign that we want to do some investigation and see what's going on. Slower, more insidious changes maybe represent a distress response to a change in the caregiver, a change in the routine. You notice that maybe they're less happy, more irritable in general. And that can be affected, and then realizing what that is and changing it can be helpful. But when you see an abrupt change and sudden hallucinations, sudden complete change in mental state, then you wanna look at medical stuff. Sometimes progression of the disease can lead to agitation with no precipitators or direct causes. And that usually expresses itself as the day moves. So later throughout the day, late day fatigue or wearing out may explain some agitation behavior that we call sundowning. So all of us get crankier as the day pass, but folks with dementia are much more sensitive and susceptible. And there's a very particular entity called sundowning that occurs. And so sundowning is also known as the sundown syndrome, is characterized by the emergence or increment of neuropsychiatric symptoms such as agitation, confusion, anxiety, and aggressiveness as the day passes, and it's starting the late afternoon, in the evening, or into the night. It was first described in 1941 as nocturnal delirium or delirium and agitation within 1 hour of darkness. So it's fairly frequent entity that's going on with folks with dementia. And once we identify that that's the case, we can address it accordingly. We know, okay, it's 5 p.m. We have to be more careful. Maybe we have to schedule a medication at that time to make sure that transition into the night is smooth. It is thought to be associated with impaired circadian rhythmicity, environmental and social factors, and impaired cognition. Neurophysiologically, it appears to be mediated by degeneration of the suprachiasmatic nucleus of the hypothalamus and decreased production of melatonin. So melatonin at 6-7 p.m. scheduled is also at the beginning helpful with sundowning. Various approaches to sundowning, bright light therapy can be seen to be helpful. A study has concluded that bright light over 10,000 lux have positive effect on motor restlessness in subjects with dementia. Melatonin, even at 22 p.m., in combination with the bright light, have also been studied and been found to be effective. Other medication, including acetylcholinesterase inhibitors and NMDA antagonists like memantine, have been shown to have some effects on sundowning, and then leading into the antipsychotics if we see psychotic symptoms. That will be discussed in later slides. Which leads us to severe agitations. We had discussed minor agitation, mild agitations that do not require pharmacological interventions. However, sometimes things escalate and we see psychiatric symptoms that co-occur with the agitation. And at that time, we are thinking of a psychiatric disturbances that is secondary to the dementia. It's not a psychiatric disorder, it's still dementia, but it requires psychotropic medications. And so the way we like to differentiate those symptoms, because they're all very different, is depending on the symptoms that is happening along with the dementia, the agitation, will guide us towards the choice of medication we're going to use. So if we see agitation with delusions, with paranoia, with accusations, who took my purse? Where is, are you trying to steal my money? This is paranoia, and this is psychosis, and this requires antipsychotic, even though we have the antipsychotic um, um, label that antipsychotics are not recommended with dementia. When we see dementia plus psychosis, this is an indication for antipsychotics. And if we don't use those antipsychotics, the patient will be very distressed, very paranoid, very accusatory of their caregiver, will probably not be successful at staying home or in his current level of care. So it's very important to be mindful of that. And so that's one of them. Agitation plus perseverating anxiety. Sometimes there's no paranoia, but sometimes there's a lot of anxiety. Where's my husband? Where's my spouse? Where's my son? What's going on with my heart? And so if it comes with a severe anxiety, panic disorder, we need to use anti-anxiety medication. If we're looking at agitation plus altered mental status, we're looking at delirium. We will talk about every one of those. Agitation plus autonomic instability, agitation plus insomnia. Every one of those requires personalized and different approach and medication to be used. There are very common medical causes of agitation in the elderly. Most commonly and most notoriously is medications itself. And so we pay attention to the medications that are being prescribed. Some of them have properties that we call anticholinergic that can lead to delirium, and that can lead to people being very confused, having hallucinations, and be very altered mentally, be very agitated. And a very simple solution would be to stop that medication, and people will get better. So that is there is a long list of medication that has anticholinergic properties. It's the Beers list criteria. And any medication on that list is not considered geriatric friendly. And so any geriatric patient should be very careful with when prescribed those medications. And they can lead to delirium and agitation in the elderly. So that's a very easy fix. We look at those lists. UTIs, urinary tract infection, is also notorious to cause agitation in folks with dementia. So if we see an abrupt change in behavior, a very simple urine analysis that diagnoses a urinary tract infection can be very helpful. We start antibiotics, people get better within a few days. Other lists of medical issues: poor nutrition, respiratory infection, strokes, head traumas, withdrawals, COPD, encephalopathies, akathisia. All those are medical causes that by themselves lead or induce agitation. And if we address the medical cause, people get better without necessarily it being a psychiatric issue. Once we have to use psychiatric medications, we have to be very careful. This is a geriatric population that are very sensitive to many side effects. So there's a geriatric golden rule of starting low doses and going very slow. So we start low and we go slow to make sure our medication are helpful without them being sedating or without them causing their own trouble of falls and having fractures and having medical complications. So as I said, drug-drug interactions are common, side effects are common. Side effects have serious consequences, including falls, hip fractures, etc., which lead to very high morbidity. So though we want to use the medications, we also want to be careful and start with the very low dose and go up slowly. I mentioned the Beers criteria. It's published by the American Geriatric Society. It emphasizes deprescribing medications that are unnecessary, reducing polypharmacy, medications that have anticholinergic effects, medications that have been prescribed 10 years ago and continue to be prescribed without necessary benefit at the moment. So minimizing those will minimize risks, and it provides information about the ones that are ineffective or cause morbidity in the elderly. So it's an important list and criteria to keep in mind. We can go over now the medications that are used, the classes that we usually use, depending on what we see in terms of comorbid psychiatric problems. And so antidepressants, common antidepressants, SSRIs, are commonly prescribed when we see agitation and anxiety with folks with dementia. And so this can help decrease agitation among folks who are exhibiting a depressed mood, anxiety, no paranoia. Lexapro and sertraline, escitalopram and sertraline are the most geriatric friendly out of those antidepressants. Paroxetine or Paxil is the least geriatric friendly and the one that should be avoided. Tricyclics are also to be avoided. They do have anticholinergic side effects and they have tons of side effects. So we prefer to start with the SSRIs. Hypnotic agents are used when we see agitation and insomnia, and when we see people struggling to fall asleep, and maybe a complicated delirium or a complicated sundowning that is leading to a sleep-wake cycle. And so folks are agitated, pacing at night and sleeping during the day. We can reverse the cycle while using hypnotics and medication that put people to sleep. Most of those are also, we need to be careful with the dosages. We don't want folks to be sedated, to fall, to have fractures. Trazodone is a good geriatric-friendly, effective medication. Benzodiazepines like Ativan or Xanax are not recommended. They have a significant risk on worsening cognition, decreased reaction time, and increased risk of fall. Also, there is a risk of paradoxical reaction that is more common with the elderly. So what that means is this medication will disinhibit the patients and will make them even more agitated. That doesn't mean that it's not a very effective medication, and if sometimes we use it, if we have we choose lorazepam among that class. Anti-epileptics and mood stabilizers is another class. We use it in agitation that comes with disinhibition, with something that looks like mania, where folks are sexually disinhibited, are acting out of their nature, they're grandiose, and that's helpful in dementias that are frontotemporal, that are impulsive, restless, hyperactive, but are not psychotic. So valproic acid is a very common mood stabilizer that can be used at that time. There is an old literature for carbamazepine, but it hasn't been used it's less used in practice nowadays. Gabapentin is a favorite in the geriatrics, a geriatric-friendly medication because of its large therapeutic index. You can start with a very low dose and work your way up. It has been used, this has been very helpful for agitation with anxiety. It has been helpful with pain and with insomnia. So if you have a trifecta, gabapentin is good to think about. There have been case studies, case series where it's been helpful with vascular dementia and mixed vascular and Alzheimer's dementia. So it causes less sedation, less dependence, less delirium than the benzodiazepines, and hence is preferred over that class. When we see psychosis, as mentioned earlier, when we see paranoia, when we see hearing voices or seeing things that are not there, then even though we have a black box warning against those medications, this is the only medication that will help. And so we will have to use antipsychotic medications. It is used in the elderly to treat aggressive behavior, agitation that are accompanied by delusions, hallucinations, even though it's secondary to dementia. It may increase the risk of mortality in the elderly, but it is, at the time, the risk is much higher if that behavior is gone untreated. Stroke, sedation, falls, further cognitive impairment, metabolic syndrome are all potential side effects, and these are medications that need to be prescribed carefully. Parkinsonism and tardive dyskinesias in the older antipsychotics is also a risk. So we avoid this class in general unless we see symptoms of paranoia and psychosis. This is a list of the most common antipsychotics. Most frequently, risperidone is going to be very helpful. It has higher likelihood of extrapyramidal Parkinsonism, but it is very effective. Olanzapine is also very effective. However, we have been seeing more case reports of delirium and anticholinergic effects. So to pay attention to that if we see it. Seroquel or quetiapine will be used in case of different types of dementia that come with Parkinsonism or Lewy body dementia, is when we mostly use that drug. And then aripiprazole is also an antipsychotic that has less sedation and can be very helpful in this situation. And if all those second generation newer medication fail, then Haldol is also a very effective, very commonly used option. So these are the most common classes and most common indication of medications that are used. Other compounds have been researched. I can talk about them, briefly mention them. But so far, they have not been shown to be superior to the commonly used medication, so they are not being used, but we continue to research different compounds. So prazosin is one of them, and has been researched and has shown some effect. Propranolol is another one of them that has been studied for disruptive behavior in nursing homes. Those two medications need escalating doses to reach good effect, and so has a lot of side effects in terms of dropping blood pressure and heart rate. And newer medications like dextromethorphan quinidine is in current randomized clinical trials. And is also to be mentioned. Most recently, there was an FDA approval for the first drug that is approved for dementia, and it's caused a lot of excitement in the community, and it's brexpiprazole. The excitement is less shared by psychiatrists because we know how the drug works, and it works like aripiprazole, a medication discussed earlier on. It doesn't have an FDA approval for it, but it works similarly and has been used for many years. And so it's not a new mechanism for the agitation. It's just a newer antipsychotic that has been studied in that field. It's still an option, and it's good to know and keep in mind. And they studied 2 different dosages, 1 to 2 milligrams or 2 to 3 milligrams. And it looks like the effects start at 2 milligrams. And so brexpiprazole is a partial agonist-antagonist of D2 and D3. And so very similar to aripiprazole, though maybe a little bit more sedating. And that's the chart. You can look at brexpiprazole and aripiprazole on the level of dopamine agonism and antagonism compared to antipsychotics versus compared to dopamine agonists in Parkinson treatments. This is where that medication sits. It is one new option, though not as life-changing as we would expect compared to the other older options. So this concludes the list of medications that I have that can be used and concludes my presentation for you. That's it.